Okay, so we're going to finish what we didn't finish in class on the association between physical activity and mortality. We're going to finish by talking about fitness and mortality. Because if you remember in our assumptions of physical activity epidemiology, the assumption is that physical activity leads to fitness, and then fitness leads to decreases in mortality. So whether or not physical activity leads to fitness is another debate for a different day. Okay, so we're going to talk about the ACLS study. So that's the Aerobic Center for Longitudinal Research. The background is that there were 13,000 participants, 3,000 females, and they had to be referred to the Cooper Clinic for cardiovascular complications. So note that's our population, right? Individuals who were already at the very least suspected to have cardiovascular complication. They had to achieve, however, greater than or equal to 85% of age predicted heart rate max on the treadmill test. So they are at least capable of exercising at high intensity with symptom-free. So they couldn't have symptoms while getting to that point. So apparently healthy. No evidence of heart disease, diabetes, abnormal ECGs. Baseline data was collected. They had a physical exam, blood draws, anthropometry, which just means height and weight, BP for blood pressure, treadmill test, which is what is talked about above. And then you had a health history questionnaire and a physical activity questionnaire. The follow-up lasted through 1985, and the average person was followed for 8 years. So if we think back to sort of our person year data, right, if the average person was followed for 8 years, and there were 13,000 people in the study, right, we could multiply that by 8, and probably my follow-up would have been something like, what is that, 104,000 person years. In that time, 283 deaths occurred, 240 were in males, mostly from cardiovascular disease and cancer. Okay, so that's our population. Here are our risk factors, and these are called stereograms. They're kind of intimidating. I want you to take them one at a time, so looking at in that upper left-hand corner, and see if you can dissect what's happening here. So I'll help talk you through, I guess, this first one. So on the left, we have relative risk, right? So we already know what that is. Relative risk is the ratio of two incidence rates. And incidence rates, right, are the number of people, the number of new cases in the population, okay? So the number of new cases in this case would be deaths occurring, okay? So the number of deaths occurring in a population that fits both of these criteria. So they're low in fitness, so they have the lowest level of fitness among this group. And then they have high blood pressure, high systolic blood pressure. Okay, so in individuals who have high systolic blood pressure and low fitness compared to individuals who don't have, or compared to individuals with high fitness and low blood pressure, right? We see a relative risk of roughly, it looks like maybe 2.5. Interestingly, with elevated blood pressure, but not hypertensive blood pressures and low fitness, we actually see a greater relative risk. And you may see that partly because there weren't a ton of deaths in this study, right? So perhaps that's sort of what the data looks like, but you can see a clear trend across fitness categories. So as fitness goes down, we see increased risk. And it looks like, because the trend is very clear from from this left side to the right side in terms of going up, it looks like maybe fitness plays a larger role than blood pressure does on mortality risk, okay? So, and then over here on the right, we have number of deaths, okay? So I want you to see if you can figure out what these other three mean by taking a look. So I'm not even gonna pause the video. I'm gonna sit here with you and look at each of them. So starting with cigarette smoking, what associations do we think are happening here? Okay, so if you need more time on this one, you can pause the video. I'm not looking for anything super groundbreaking, just to notice. So the trend from left to right, is that right? From right to left, sorry, is right. We do see that fitness, it looks like generally we're increasing across fitness levels. So as fitness level decreases, we have increased relative risk. And then when I look front to back, right, I also sort of see the same trend. There's that middle one that looks a little suspicious. We're not quite sure what's happening there. But generally speaking, as I go from never having smoked to an ex-smoker to a current smoker, right, I have increased risk. Now, we don't know in this study, well, how did they categorize current smoker? Is that one cigarette a day, one cigarette a month, one cigarette a year, right? So we know from other studies that there's typically a dose response association with mortality. So as the number of cigarettes smoked goes up, mortality goes up. But we don't know the individuals in this smoking group how many cigarettes per day they're smoking. But generally, we see increased risk with smoking, increased risk with low fitness. Okay. Then coming down to body mass index, give you 20 seconds to look at that one. Okay, so really similar shape as the cigarette smoking. So I would say it looks like BMI, as BMI goes up, we see increased risk. And as fitness goes down, we also see increased risk. Actually, in this, sorry, I'm re-looking at this right now. I should have been looking along with you. In this, it's saying that actually high BMI is down here. I would guess that this is a typo, that these categories should have been flipped, that less than 20 is down here. And I have read this paper semi-recently, so I'm pretty sure that's correct. But in any case, actually what this figure is suggesting is that higher BMI is negatively associated with mortality. Now, we did see that in the non-communicable disease population, but in an apparently healthy population, I wouldn't expect to see that same trend. And if I remember right, that's not, in fact, what they see, that these labels are mixed up. And then last one, total cholesterol, pretty similar trend as well, right? Fitness, we see is associated, sorry, fitness is across this axis. So fitness we see associated with increased risk. Total cholesterol, as cholesterol goes up, right, we see increased risk as well. Now I want you to compare the relative risks of the different categories. Okay, so look at the highest risk, so that back left corner. What do we see between the differences between the four risk factors here? All right, so blood pressure, systolic blood pressure seems to have the lowest relative risk, the lowest increase in relative risk, followed by cigarette smoking, then total cholesterol, then BMI. Now, as much hate as BMI gets in our field, right? In this case, it's a pretty good predictor of mortality, right? Your relative risk goes up more with body mass index than it does with smoking. So something to sort of keep in mind when you're looking at data in the future. So looking at the development and progression of disease, those four risk factors, where would they fit in our sort of mechanistic flow chart here? So systolic blood pressure would go where? It should go pretty squarely in hypertension. BMI, where are we going for that? So we should be going right pretty clearly through these two, dyslipidemia and adiposopathy. And we're going to get into that later today. How about smoking? Where do we think that fits in? So smoking could go a couple of places. I could see definitely some increased inflammation and some increased arterial injury. So I might see some atherosclerosis. I may also see some increased hypertension. And then cholesterol, where do I see that going? So I could see that a lot of places. Cholesterol, definitely dyslipidemia, pretty squarely fits there. However, cholesterol is also really closely associated with atherosclerosis, with adiposopathy, with insulin resistance, and then indirectly maybe with hypertension. Okay, so that one kind of fits in all of our categories. Okay, so now I want you to read this figure caption, and I want you to see if you can calculate the relative risk, right? This already tells you what the relative risk is, but this caption now gives you the information you need to actually calculate the relative risk of, let's say, this back left group. Okay, so take a minute and read that. Okay, so remember, relative risk is the ratio of the incidence rate of two groups. It tells you in there that the relative risk of the front right cell is set at 1, okay? Meaning that that is my reference group, okay? So that group still has an incidence rate, right? There were still people who died in that group, okay? But that incidence rate is 16 over 10,000, right? 16 per 10,000 person years. Then the back left column that has an 80 on top, the incidence rate there was 80 per 10,000. Okay, so if we then take that data and we say, I'm just going to do this on my phone with you. We do 16 divided by 10,000. And then, so that gives us 0.0016. And then we do 80 divided by 10,000. And that gives us 0.008. We take the 0.008, so the incidence rate of my exposed group, and we divide that by 0.0016, which is the incidence rate of my unexposed group, right? My reference group. And that should give you exactly 5. Okay. Which is what we see here, right? That relative risk of this back left group is 5. So I would love it if you took a minute to see if you could calculate the incidence rate of one of these other bars, just so that you start to see like, oh, the math works out, and you get used to what is a relative risk. Okay, what is an incidence rate? If I had to explain what the incidence rate was in a sentence, could I do that? Because theoretically in your papers, right, you should be able to explain to me, okay, the relative risk of the sedentary group was 4.5. Okay, sedentary compared to what? So sedentary was my exposure. What was my unexposed group? Is it just non-sedentary people, right? So be able to say that in a sentence. Okay, and then using this same data, we did a stratified analysis, right? So stratified meaning I broke my groups up by age. And we looked at low fitness, moderate fitness, and high fitness. And you see a very clear dose response association here, right? So as my fitness increases, my mortality rate decreases, okay? And we see that really clearly between 60 and 69, and between 70 and 79, between 80 and over 100, right? We don't see that as much. So we do see the low fitness group as having really high mortality, but actually we see a little swap here, okay? maybe take a minute and think, why might I see individuals with high levels of fitness at 80 plus years having higher mortality? So one possible reason is if they have higher fitness, they're capable of doing more things. So they're maybe getting out more. So maybe they feel like they have a higher degree of independence. They may live alone, right? Because they are capable of doing so. So maybe they expose themselves to greater risk for, say, a hip fracture or injuries, right? And I believe in this analysis, this wasn't a statistically significant difference, but it's a really good practice to get in the habit of thinking, okay, if the finding isn't what I would expect, what could explain it? Okay, so take home number one, there's a strong inverse curvilinear dose response between fitness and mortality. Now, that doesn't look very curvilinear to me. Maybe here, right? Not quite linear, maybe a little bit bigger of a dip down there at the bottom, right? But really pretty linear. Um, and we see that in both men and women, and that persists when adjusting for other major cardiovascular disease risk factors. There's a lot more we could go into from this study, and you are more than welcome to go look it up on your own. But those are the take homes. Greatest benefits are typically seen between 9 and 10 mets, which if we're converting that into a VO2 max value, right, you're looking at about 35 mLs per kg per minute. Okay. Now, they also looked at, so that was just association. So one risk factor and one outcome while adjusting for other variables. Now they wanted to look at a change in fitness. So, right, most of the cohort was male. And so you see that the sub cohort where they looked at change in fitness is exclusively male. So they had to do at least 2 exams to measure change over time, right? And they looked at apparently healthy versus unhealthy groups. So again, collected all the same data, but really we're going to look at just that treadmill test data. And then there was again follow-up, average of about 5 years until they hit the second exam, 223 deaths. And then quintile 1 is said to be unfit, and quintiles 2 through 5 were associated with higher fitness. Okay, so note, having that as the background, I want you to see if you can tell me what's happening here. Okay, feel free to pause the video if you need a little more time. But my y-axis, right, so my outcome variable, I'm looking at all-cause death rate, so mortality again per 10,000 person years. And then my x-axis, right, I've got age, age as a categorical variable here, okay? And I see unfit at both exams, unfit at the first exam, and then fit at the second, so an improvement in fitness, and then fit at both exams, so no change in fitness, but considered fit. And you see again here, pretty clear dose response relationship. Okay, so improving fitness definitely results in decreased risk, but not quite as low a risk of individuals who remain fit at both exams. Okay. And we see that pretty clearly through each category. The other thing to take note of is, right, as age increases, mortality rate increase. So my black bar to black bar to black bar to black bar, pretty clear dose response there, there. And then if I go lightest bar to lightest bar, fairly clear, maybe curvilinear. But, right, that's what we would expect. If we get older, our risk for death increases. Okay, and then this is your healthy versus unhealthy comparison. So in healthy men, how much did my risk decrease with a 1 MET improvement in my VO2 max? And in unhealthy men, how much did my risk decrease? So what we see here is that you have a reduced risk in all men. If you improve fitness, then you're going to reduce your risk for mortality. However, in healthy men, you may actually reduce it to a greater extent. So, but whether healthy or unhealthy, improvements in fitness are associated with decreased mortality risk. Okay, so take home number 2, men who maintain or improve fitness are less likely to die. This persists after adjusting for leading CVD risk factors. So you can go in here and look at the risk factors that they controlled for. The improvement in fitness was most strongly associated with improved risk for mortality versus improvement in other leading CVD risk factors. So that sort of comes back to this. Oopsies. This. So fitness in this case was a more important predictor than cholesterol, BMI, systolic blood pressure, or cigarette smoking. Okay. All right. Let's take a 5-minute break and then we'll come back for some article specific content.